Hi everyone, you've joined the webinar Motivating Action, Going Beyond Awareness Raising to Have an Impact. We'll be getting started in just 1 minute. Please note that you are currently in mute mode, so if you have a question, please type it into the webinar chat box or submit a question through the Q&A. Welcome everyone to our webinar, Motivating Action, Going Beyond Awareness Raising to Have an Impact, facilitated by the Fall Prevention Community of Practice. My name is Mariel Ang, and I am the project coordinator at the Ontario Neurotrauma Foundation. ONF sponsors the Fall Prevention Community of Practice and its online platforms, Loop and Loop Junior. Marguerite Thomas will be helping me facilitate this webinar today. Marguerite is the consultant liaison for the Loop Fall Prevention Community of Practice. She will be assisting with facilitating the chat box and the Q&A feature today. Before we begin, I'd like to give you a rundown on the Zoom meeting platform. If your Zoom application is opened in full screen, you can double-click or press the escape button on your keyboard to exit the full screen. There should also be a button in the top right corner of your screen that says Exit Full Screen. This webinar technology consists of 2 parts, audio and visual. Both visuals and audio can be provided through your computer monitor and speakers. To test your audio settings, look for the audio settings or join audio button in the bottom left corner of your screen. This will provide options for testing your computer microphone and speakers. If you would like to alternatively join the webinar through a telephone line, you may also do that by clicking Join Audio, and you will see the call instructions for joining the webinar through the telephone line. If you look on the center and bottom of your screen, you will see a few of our Zoom platform options. The chat box is available to you if you would like to get in touch with one of the panelists. You may also raise your hand if you are experiencing technical issues, and there's also a Q&A feature. During the presentation at any time, if you have topic-related questions for our presenter, you may submit a question through the Q&A box. Once the presentation is complete, I will read all questions aloud and allow our presenter to provide her response. If at any time you need to leave the webinar, you can find the Leave Meeting button in the bottom right corner of your screen. The webinar is being recorded, and a YouTube link will be sent to all participants in about 1 week, along with the presentation slides. If you have any questions about the technology at any time during this presentation, please type them into the chat box or use the Q&A feature on Zoom. Alternatively, you can email me at mariel@onf.org, and I will work with you to resolve any technical issues as soon as possible. I'll be adding my email address in the chat box shortly. I would now like to introduce our presenter, Dr. Julia Moore. Dr. Julia E. Moore is the Senior Director for the Center of Implementation. Dr. Moore has a PhD from Penn State, where she was trained as an implementation scientist, researching the best ways to implement evidence-based programs. Dr. Moore is most passionate about supporting professionals in how to use implementation science in the areas of health, public health, and mental health. She has worked on over 75 knowledge translation projects and delivered dozens of workshops and webinars to over 1,000 participants. Without further ado, please take it away, Julia. You may now share your screen.
Wonderful. Thank you so much, Mariel. I am going to share my screen and get started. So before I jump right into content, I want to give a bit of background around how I ended up here and the kinds of work that I've done and how it kind of relates to the kind of work you might do. So I am Canadian and did my undergrad at U of A, where I ended up doing a lot of work in psychology. Afterwards, I left and ended up going to Penn State, where I did my PhD. And while I was there, I was so fortunate and really just lucky that there was a center that was opened called the Epicenter that supported the implementation of evidence-based programs across the state. So when I was first started, it was there because the state had been funding community organizations to implement evidence-based programs. And a decade later, they realized you can't just fund people to implement evidence, you need to support them. So they created this Epicenter. And I was the first graduate student there, so I got to do things no graduate student should probably get to do. And I fell madly in love with the idea of how can we support organizations to implement evidence? And how can we help them use implementation science, which we'll talk about today, to inform those efforts? I then returned to Canada and spent 7 years at the Knowledge Translation Program at St. Michael's Hospital. And I've now been for 1 year at the Center for Implementation, working with organizations who are positioned to implement and spread and scale evidence in a large way. So I was trained as a scientist, but I don't actually work as a researcher now. I work on helping people implement evidence all day, every day. So first I want to talk about a little bit of an introduction to implementation. So we believed for a very long time in the kind of field of dreams analogy. So in Field of Dreams, they say that if you cut down cornfield in Iowa and build a baseball diamond, then Shoeless Joe Jackson is going to return to play baseball. And we thought that if we built evidence and evidence-based programs and evidence-based guidelines, that people would show up and use them. But we now know that is absolutely not true. That is not the way it works. We have lots and lots and lots of evidence, but people are not using it. In fact, the research shows that it takes an average of 17 years for evidence to be used in practice. 17 years go by before people are actively doing what we know works. And if you look closely at those studies, it isn't even everyone who's using it 17 years later. And so we can and need to narrow that gap. And so how do we do that? Well, there's a whole bunch of different disciplines that kind of all are working on this same goal. Unfortunately, we have a bit of a naming problem. There's even research to show there's over 100 different synonyms talking about how we close this research to practice gap. And what I always tell people is, I don't care what words you use the words that make sense to you and your organization, but make sure you define them. Make sure you all know exactly what it is that you are talking about, because it's our lack of consistency that is so confusing for many people. So a lot of people in Canada think about the terms knowledge translation, knowledge mobilization, knowledge transfer and exchange. And a lot of those terms I really think of as umbrella terms. And they're umbrella terms capturing a whole bunch of different concepts. And so if we drill down and better understand what is included in this large umbrella, we can really think about our own work and how we can do it even better. So essentially the idea is that all of these things exist along a spectrum. At one end of the spectrum, we have dissemination, and at the other end, we have implementation. When we disseminate, what we are essentially doing is sharing information, ideally in a back and forth way. Dissemination is about increasing awareness. It's about increasing knowledge. We can do this passively or actively. And the act of actually doing dissemination is called dissemination practice. But underlying the practice of dissemination is a science. There are researchers out there who are studying what are the best ways to disseminate information. What's the best way to summarize systematic reviews or create websites or new infographics? What's the best way to use Twitter or other forms of social media? And so people who are researching dissemination are doing dissemination science. And ideally, the practice of dissemination should be informed by the science of dissemination. On the other end of the spectrum is implementation. And this is where we use strategies to help people actually adopt new practices and change what it is that they're doing, to change their behavior. And so again, we have a practice of implementation, which is about the act of actually doing it. And underlying that is a science. So there are people who are studying what are the best methods to implement. What are the factors that affect implementation or sustainability or outcomes? And we want the practice of implementation to be guided by the science of implementation. Why do we need both dissemination and implementation? Well, a lot of our work is typically focused on dissemination. And that is good and very helpful for some things. It increases awareness and it increases knowledge. But dissemination alone only changes outcomes about 1% to 2%. And so that is often, we expect much bigger impacts than you're really going to get with dissemination alone. And that is why we need to think about implementation if we truly want to change behavior, so that we can use strategies to create that behavior change. So before I go any further, we're going to jump into doing an activity. So we are going to try this. We've never annotated with this many people, so we are going to try it. But essentially, there should be a button that allows you to annotate. And Marielle, if you want to jump in and help people, oh, I just drew one. There's a button that should allow you to annotate. Here it is, perfect. And so you want to click on this annotate button. And once you click on it, you should have some options of what you can do. The stamps are really great. You could use a little check mark, little arrow, any of those things. Or you could use the drawing tool and just kind of draw your own lines and stuff like that. And so what we're going to do is I'm going to go through a bunch of different examples and get you to think about what it is, which best describes that situation. So the first example is, actually before we even get into the example, I want people to just take their annotate, because I can erase it. Take your annotate button, try to draw something. So I'm going to draw like a little circle here. Try to draw on the screen and see if you were able to draw on the screen. Some people say, I don't see the annotate button. I don't have that function available. All right, so if people cannot annotate, then what we're going to do is get you to write in your in the chat box the answer to each of the questions. So what we'll do is, so the first question is, the Fall Prevention Month campaign includes a social media guide to raise awareness. Do you think this is an example of dissemination practice, dissemination science, implementation practice, or implementation science? So write it in the box and perfect. Lots and lots of people answering. I see. I'm just going to give it a moment since there's many more coming. So it looks like almost everyone is saying dissemination practice, and there were a couple of implementation practices thrown in there. So this is a perfect example of dissemination practice. And it's dissemination practice because it is sharing information. Social media is about sharing information, raising awareness. So that lands on the dissemination side. And it's the practice of doing it because we're not asking a research question, we're just actually disseminating. And so it's the practice of doing it. The second question is, a community delivered a new Tai Chi program to seniors that has been shown to reduce falls. Is this dissemination practice, dissemination science, implementation practice, or implementation science? Wonderful. Whoa, so exciting to see so many people answering. Wonderful. So it looks like almost everyone got this one. This is an example of implementation practice. So the reason it's implementation is because it's an actual program that's designed to change people's behavior. So it's a Tai Chi program. So the idea is that people would go and participate in Tai Chi. So it's about changing their behavior, not just increasing their awareness or knowledge about the importance of movement, for example, but actually doing it. And because their community is delivering this program, it's an example of practice. They're not studying whether or not this program is effective, and they're not studying the science behind what impacts the effectiveness of this program. They're actually delivering it, which makes it the practice of implementation. The third example is a group wants to assess the contextual factors that affect the implementation of a mobility program for seniors. Is this an example of dissemination practice, dissemination science, implementation practice, or implementation science? Wonderful. So it looked like there was a bit more diversity in this one. There was implementation science was the most common answer. There was a bunch of dissemination science, and even some people able to say, I'm not really sure where this falls. So let's look at it more closely. So the group is assessing the contextual factors. So they're answering research questions around which contextual factors are going to affect something. So that's a science question. So it seems like almost everyone got on that science side of it. And then for the second part, we're talking about the implementation of a mobility program for seniors. And so we're going to have to make a few assumptions, but the idea is if it is a mobility program that is being implemented, that means we are probably using implementation strategies to change their behavior related to mobility. So it lands further on that implementation end of the spectrum than the dissemination end of the spectrum, because we're actually trying to change their behavior in this mobility program. If we were just trying to raise their awareness, then that would be about the dissemination side rather than the implementation side. So I have two more quick ones to go through. A research group wants to collaborate to compare whether social media or presentations to colleagues are a better way to increase knowledge. Is this an example of dissemination practice, dissemination science, implementation practice, or implementation science? Wonderful. It looks like this was the most consistent answer that we saw. So it seems like almost everyone said this is dissemination science. And so yes, this is dissemination science. We are looking to compare two different dissemination activities. Social media is a form of dissemination, and presentations to colleagues are about increasing knowledge. And it even says, are they a better way to increase knowledge? So that lands on that dissemination end of the spectrum. And it's science because we're asking to compare which one of these two is a better way to do it. So it's asking a research question about dissemination. The final example is the team uses reminders, education, and champions to implement a new fall prevention program in long-term care homes. Is this an example of dissemination practice, dissemination science, implementation practice, or implementation science? Awesome. So we have a lot of different answers here. I would say most of them fall in this implementation practice bucket, but a few questions and funny responses. So we would consider this an example of implementation practice because they're using strategies. Specifically, reminders is an implementation strategy, education is an implementation strategy, and champions are an implementation strategy. Because these are strategies designed to change people's behavior. So the act of using those strategies makes it implementation because we're not just raising awareness, we're actually trying to change people's behavior. And it's the act of actually doing it rather than studying it because we're just saying we're using these reminders to implement this fall prevention program. So this is an example of implementation practice. I'm going to jump into the next section, but if people have remaining questions about this, you can add them to the question and answer box, which Marielle is going to flag, and we can talk about at the end. So I just want to share that I know a lot of people who spend a lot of their work doing dissemination practice. And once they learn about the idea of this, they kind of say, well, I want to do implementation practice, but my organization isn't totally there. We're not really doing it yet. And there's this really great article from 2017 by Annie Neiman and Anne Cristiano in the Stanford Social Innovation Review. And it talks about how we need to stop raising awareness and really accentuate our calls for action. So it isn't just about raising awareness and letting people know something's happening, but letting them know what they can do. And so if you're learning about this idea of dissemination and implementation on a spectrum, and you feel like your work is really on the dissemination side, but you slowly want to move your way down that spectrum, I would say this is a really great place to start. And they actually have two papers, Anne and Annie, we call them the Anne and Annie papers, that you can go and check out. But if you are thinking about the implementation side, we want to make sure that our implementation efforts are truly informed by implementation science. So what does that mean? Well, the first thing is, oftentimes when we try to implement and create change, what we do is kind of like rolling the dice or throwing spaghetti on the wall and hoping that something is going to stick. But we instead want to be more strategic. We want to be thoughtful and proactive in how we approach our implementation efforts. Implementation and creating change is hard. It is very, very hard. But if we can be proactive in making that happen, then we can set ourselves up for much more likelihood of success. And I want to flag, people asked me to repeat the authors. We will share the names of all of those with everyone afterwards. But it's Annie Neiman and Anne Cristiano. And if you Google Stop Raising Awareness already, you'll find it. So what are the foundations of implementation science? Well, there's really three key components that make up this foundation. It's the use of process models, theories, and frameworks. Process models outline the steps or stages needed to go through something, in this case, implementation. So it lays out what are the steps and stages you might encounter along the way. It is a great place to start because it gives you a bit of a roadmap on what you can do and how to make that Second, we need theories. Theories scare people, but theories are where it is happening. Theories talk about how we can predict things, and they talk about causal mechanisms. What is the mechanism of change? How is it that you are going to create change? In any change effort you're part of, you have a theory of change. It just might not be explicit. You might never have said, these are the assumptions about how we are going to create change. But often our assumption is, I'm going to give people information that's going to raise their awareness, and then they're going to change. But that theory often doesn't hold true. And so by using existing theories of change, we can increase our chances of success. And I'll talk a little bit more about theory today. Finally, we also need frameworks. Frameworks help us explain the different factors that influence things like implementation and outcomes. They're often collated lists. And when you look at a framework, many times you look at most of the things and think, yeah, I already know about that. But what's amazing about frameworks is they bring together so much research that they're much more comprehensive than the things we would automatically think of. And so by using an existing framework, it again increases the chance of success. And we're trying to prevent this situation. So I often get brought into projects when things did not work well, and people come in and say, Julia, we need help in implementation. And I ask them, well, what is it that you did? How did you expect to create change? What is that mechanism, the theory of change? And this is essentially what they're telling me. And so when we proactively use a theory and think about change differently, we can set ourselves up for success. So how do we do that? Well, we can start by understanding barriers and facilitators to change. So what does that really mean? Well, essentially, if you are implementing something, we're going to call it an innovation. An innovation being essentially a description of any new thing you want to change. That innovation is really made up of two big buckets. You have what we call an ideal practice. This is the thing you want people to do differently. This is the what. It might be a guideline, a best practice, a tool, a resource, a policy. And ideally, this practice should be guided by evidence. So you should have evidence that this is, in fact, a good thing to do. In addition to your ideal practice, you need something else. Because just because we want someone to do something different doesn't mean they're going to do it differently. And that's why we need implementation strategies. These are strategies that we use to change people's behavior. Things like education, training, reminders, communities of practice, audit and feedback are all examples of implementation strategies that we use to change people's behavior. But we don't just want to pick any implementation strategy. We want to pick strategies that link back to the ideal practice using behavior change theory. Let me give you an example of why this is so important. So we know that all healthcare workers should get a flu vaccine, right? This is the what. This is the ideal practice. All healthcare workers should get a flu vaccine. There's lots and lots of evidence that this should be happening. And we can use strategies to change people's behavior, like reminders. Reminders are an evidence-based implementation strategy. They've been shown to be effective at changing people's behavior. But do you think that reminders are likely to be very effective for flu vaccines? The answer is probably no, because reminders are effective if the underlying barriers and facilitators to change are about memory. And the main barriers to getting a flu vaccine aren't about memory, but about other things like people's beliefs. And so just using a reminder is not likely to change their behavior. And so we need to connect these two things using a theory. If you already have a theory that you use, I would say go for it, keep using it. But if you don't, the COM-B is a great way to start thinking about theory. The COM-B essentially says that in order for people to change, you need three big things to have. You need to be capable of change. So that means you need the knowledge and skills to change. You need the opportunity to change. And you need to be motivated to change. In healthcare and in public health, we are great at focusing on capability. We love giving people knowledge and skills. We are increasingly thinking about opportunities and how can we create an environment that is supporting change. But we often neglect this motivational piece. But motivation is critical in creating change. Another way to think about this, so the next slide I'm going to share, some people find overwhelming and some people find really helpful. So if you think it's overwhelming, you can sort of close your eyes and plug your ears. But it does help some people think about these three things. So essentially, this theory of change, which thinks about those mechanisms, is linked to a framework that has 14 different domains. And essentially, it's providing more detailed definitions of what lands into each of these different buckets. So in the capability bucket, we have things like knowledge. So are you aware of something? Do you have the skills to do something? Do you remember to do something? Or is it a habitual behavior? So is it a habit that's an unconscious behavior you don't even think about? All of these things are examples of capability. In the opportunity bucket, we have things like the environmental context and the social influences in that context. It's just about that context and is it supporting the change? And under the motivation bucket, we have 8 different constructs. Things like beliefs about capabilities. Essentially, is someone confident they can make the change? What about the beliefs about consequences? Are they worried something bad is going to happen? What about their professional role and identity? This one is huge. I hear this on almost every implementation project I work on, where people talk about, I don't know if that's really my role to do that. Some people have general optimism or pessimism about change that influences their motivation. People's goals and intentions are essentially saying, do you want to do this? That's a goal. And do you plan to do it? That's an intention. People can have emotional reactions. And as much as we like to believe that people are rational beings, that we are rational beings, the reality is many of us are actually driven by our emotions. And so when we can understand those emotions, it can help inform our implementation efforts. And finally, some things reinforce either the behaviors we want in people or that we don't want. I'm going to give one more personal example and then get started getting ready for another activity. So we're going to talk about sleep. So I personally need quite a bit of sleep to be a functional, effective, pleasant human being. And so the idea is the evidence-based practice related to sleep is that we should all be getting 8 hours of sleep. Sometimes I think 8 is a bit extreme. So 7 is good enough for me at this stage of my life. So I want to be getting 7 hours of sleep. There's a huge emphasis on increasing people's knowledge related to sleep. Oh, you need to know how important it is to sleep. Well, someone like me doesn't have a knowledge problem. I know I need to sleep. For years, I had a skills problem because I wasn't great at falling asleep or staying asleep when I woke up. But I even got over that until my second child was born, at which point I started having opportunity problems related to my sleep. Because I had a little baby who did not sleep well at night and he liked to scream and he had colic. And all of a sudden, I couldn't sleep because of opportunity issues. For me, I've never had a motivation problem related to sleep. Skills, yes. Opportunity, yes, but never motivation. My husband, on the other hand, is great at sleeping. He has no problem sleeping. He doesn't even wake up when our kids wake up, but he has a motivation problem related to sleep. And so different kinds of implementation strategies would be needed to change our behavior. You might be worried that you're going to have to change so many people's behavior that this would be overwhelming. But luckily, people's behavior often groups into these broad categories. And that's the beauty of using the COM-B and that theoretical domains framework, that's those 14 different domains that map out, because many different people's barriers fall into the same bucket, and you can use that to guide your implementation. 2 quick notes before we jump into our next activity. You have to remember that barriers are going to happen at multiple levels. We've been talking about individual level barriers, and that is a great place to start. But ultimately, you're probably going to have team level barriers, you're probably going to have organization level barriers, and you may even have system level barriers. And so you have to think about the barriers and facilitators at the different levels. And you will need to use different theories and frameworks to even think about those. So right now we're focusing individual level barriers because I think that's the best place to start. And finally, you want to remember that we not only have barriers, but we also have facilitators. And it's easy to forget that, but we can leverage those facilitators as we plan for implementation. So we are going to jump into our next activity. And so again, in the chat box, we want people to write in either capability, opportunity, motivation, or even just C, O, or M for the few examples I have here. And if it helps you, you can look at the boxes on the right, because sometimes I think that that can help you think about the barriers, which one of those 3 it is. So it is not my job to document faults. Is this a capability issue? Is this an opportunity issue? Or is this a motivation issue? Beautiful. So almost everyone is saying opportunity, and I love that, but it could be a bit of opportunity, or everyone's saying motivation, but it could be a bit of opportunity. So I completely agree. This is predominantly would fall under this box, social and professional role and identity. And so it's a motivation issue. But sometimes it truly isn't someone's job, in which case it may actually be an opportunity thing. But if you listen closely to people, oftentimes when they're making this statement, it is because they are unmotivated to change, rather than because it's truly a role clarity thing. The next example is senior management talked about this fall prevention project last week. I think they want to make sure this happens and happens well. Is this capability, opportunity, or motivation? Awesome. So a lot of opportunity and a few of the other things. I would say that this is primarily driven by that environment and the social influence. So having a senior manager is a huge social influence, we know, that influences someone's decisions and actions. So it's primarily an opportunity piece. But I could definitely see that some people could see how you could present an argument, it might fall somewhere else. One of the things I like to tell people about this is, often we have assumptions when people are talking, and what it really means is we need to ask a follow-up question about that to get more information and think about where we could map it. Ultimately, if you use the COM-B and the theoretical domains framework, it is easy to map in your head. I can map on the subway, I can map while I'm at coffee, I don't even need to see it anymore. It is not that hard to map once you get used to it. The third one is, I'm really worried that we are using the wrong screening tool and older adults are falling through the cracks. Is this an example of capability, opportunity, or motivation? And I know that almost everyone wants to ask a follow-up question before they answer this one, but assuming this is the only statement you have, where do you think it's going to fall? All right, so I see a lot of capability. What happens if I told you that this was in fact not the wrong screening tool. And there was very strong evidence to say that this is the right screening tool to be using. And people are saying they're worried about using it, but that the evidence shows it is a very good tool to use. Awesome. So I feel like people really captured that it's like, there's a possibility, there's a knowledge issue here, that people don't know about the screening tool. Maybe we actually need to change the screening tool. But if it is the right screening tool, then it's a motivation issue. And I hear this all the time in implementation efforts. And if you look closely, a person is saying, I'm really worried. That is an emotion. People don't often share emotions in words. They often express them, but they don't share them. And if a person is able to use an emotion word to describe how they're feeling, that is a huge flag that they're saying, I have an emotional reaction and I'm afraid. I have beliefs about the consequences of using this tool. And so I'm afraid to use it. Next example. Honestly, public health units are strapped. It's just not a priority here right now. Is this an example of capability, opportunity, or motivation? Awesome. So I see lots of opportunity and environmental context, and I see some people talking about motivation. So I'd agree that there's definitely a huge environmental context piece, that there's an opportunity issue here. And I can also see an argument that this could be about motivation related to people saying, this isn't really a goal. This isn't a priority right now. It isn't really a goal. So it falls a little bit up here in opportunity and a little bit down here in motivation. The final example is, we have low fall rates. I don't know why we're doing this. So imagine we're trying to do a fall prevention program. Someone says we have low fall rates. I don't know why we're even doing this. Do you think this is an example of capability, opportunity, or motivation? Awesome. So a whole bunch of capability and a whole bunch of motivation. And I say this is exactly a perfect one that falls in both of those. One, maybe people truly don't know their falls rates. And so if that's the case, this is a great opportunity to give them that data. This is a perfect example of when we might use audit and feedback to share with people what's actually happening. But sometimes this statement is really about saying, I am demotivated and don't actually want to make a change. And so that is what's really driving it. I just used 5 examples to illustrate what this looks like and how it can help you think differently about why people do change and why people don't change, and the kinds of strategies you can use. Hopefully, it'll get you thinking about things like the fall prevention campaign and thinking about, well, what are some of the barriers to change? What are some of the facilitators to change? And what could I be doing to better address those barriers and facilitators? Because when we focus only on educating people and raising awareness, we are only tapping into that knowledge box. But oftentimes, that's only one tiny piece of the puzzle. And so the more we can think about these other components, it can set us up for better success. I just want to add one little piece thinking about, as you start thinking about the strategies that you're going to implement, you sometimes can think about it in terms of these 4 different components. This is based on work by Abe Wondersman, and it's a framework called the Evidence-Based System for Implementation Support, EBSIS. And the idea is that in order to implement something, you are going to need some kind of tools. Right? They may be documents, they may be summaries, they may be something online. You're going to need some kind of training. You're going to need to actually train people to do something. You're going to need to have technical assistance to support people to make that change. And you need some kind of quality assurance. He has this great way to describe it using a driving example. And so he says, learning to drive is a complex behavior. And so anytime you want to change a complex behavior, you're going to need tools like a driver's manual, but that is not enough. You also need training, like going to driver's ed. But just because you attend in-class driver's ed doesn't mean that we're going to let you on the road. You also need technical assistance. You need a driver or someone to sit beside you as you learn to drive, a driving instructor. And finally, we will only let you on the road once we have quality assurance and you have completed a driving test. And so if we go through this extensive a process to think about how we can get people to drive, what are the parallels we can make in the kinds of programs and changes that we want? Finally, I want to add one little piece about motivation, because as you may have noticed, there were 8 different buckets that fell under the motivation piece. And so that is such a huge driver. And so when we think about it, we can really think about what else can we do to think about this motivational piece. And I'm going to share one more theory, but I promise the slide is not too scary, related to motivation and how you can think differently about motivation. So this theory is called self-determination theory. And a lot of us kind of inherently know about it, but we don't think about it in our own work all the time. And the idea of self-determination theory says that people's motivation exists on a spectrum from extrinsic to intrinsic motivation. At one end of the spectrum, we have people who aren't even going to start. They're not even going to try. So they think they'll fail. They're not even going to do anything. Next, we have people who are going to do something because they feel forced by a reward or a punishment. And in healthcare, this is often the kinds of strategies we use are actually to try to reward and punish people. And this can actually be effective at changing behavior. And the effects can be dramatic, but they are short-lived, because long-term, it does not make us motivated to want to change, because we are doing it because of this external thing. Next, we have people who are somewhat externally motivated, maybe because they feel guilty. They think they should do something. This is better than doing it because we feel forced, but still not ideal. Next, we have people who are somewhat internally motivated. So they take action because they value the goal. I might do this. I can kind of see how this aligns with the goals. Then we have people who are really internally motivated, that they do it because they can see how it relates to their self-esteem or their sense of self. In healthcare, I think that it's so great because we can think about how we can identify often with our professions, like I am a nurse, I am a public health worker, and I see this as part of my job. So that is an internally motivated piece. And finally, we have things that are truly intrinsic. You're saying, I do it because I love to do it. I don't know that we're really going to reach that for a lot of the kinds of changes we're looking for, but it's good to know that that's a goal we can strive towards. So as you're thinking about people and how to motivate them, remember that our goal is to work towards the intrinsic end of the scale as much as possible. So with that, I'm going to end with a couple of quick kind of previews and open it up for questions. So one, I wanted to share that I am so excited that at the Center for Implementation, we are in just a couple of weeks about to launch our first ever free online mini course called Inspiring Change, Creating Impact with Evidence-Based Implementation. So if this topic was interesting to you at all, I think that that would really be up your alley. It has a bunch of videos and activities for people. And so I would highly encourage you to go and check it out. It'll be coming out before the end of June. And the best way to find out more about it is probably to sign up for our monthly Implementation in Action Bulletin. So we have a bulletin that comes out once a month and profiles different projects, but also really illustrates what it means to put different theories, models, and frameworks in action. The one coming up this month is going to be all about evidence and the different ways we can think about evidence, which you know is a super hot topic. I can also add that I share lots of the hot new implementation stuff on LinkedIn. So if you go and add me to LinkedIn, I post about that stuff regularly. So if you go on LinkedIn, I would say that's a really good way to find that out. So those are probably the two easiest places to find out more information about us and what we are doing and our upcoming free mini course. So with that, I'm going to open it up to general questions. And also a question that I was talking to the community of practice about, which is, do you think that learning more about implementation science would be helpful to you? And if so, what kind of topics are you most interested in learning about? Because I presented a super high level overview of one aspect, but there's so much more that you could learn about. So if people want to post questions in the question and answer, or post any topics that you would like to learn about, we would love to hear more about those. I can also see that in the question and answer, someone asked about the 17 years for evidence to be used in practice. Is that in healthcare or in general? And so interestingly, this 17-year gap has been replicated in multiple different settings. So we see it in healthcare, we see it in public health, we see it in social services, and we see it in mental health. So it seems to be this 17-year number has kind of become an average that people use, a number that people use across a huge range of settings.
Amazing. Thank you so much, Julia, for your presentation. Again, I'm going to echo, please submit your questions in the Q&A box, and I will be able to read them aloud and allow Julia to answer them. I'm seeing a couple of questions from people asking about the references to the articles and to repeat and show the names for those articles. And the slides for this presentation will be available to all Loop members. So if you're not already a member of Loop, you can go ahead and register, and you will get an email with the link to the slides. The webinar recording will also be made available on YouTube, and that will be included in the email as well. So I see a question in here from Catherine Joyce. How can you determine the barriers to change before you implement something and or after something has already been implemented?
Catherine, that is a brilliant question. So I would say there's a couple different ways. Number one, go to the literature. There are lots and lots of papers about barriers and facilitators to change. There's a systematic review by Cabana that actually shows 293 barriers to guideline implementation. So chances are the barriers you're experiencing are probably in that list. That's a general list. But then based on the topic you're doing, say you're doing fall prevention, there are probably papers looking specifically at barriers and facilitators to fall prevention. And so you can look at those. The other way, honestly, I think you can get such valuable information just by talking to the people who are expected to change and thinking about the theoretical domains framework and the COM-B in the back of your mind as you're having that conversation and starting to map out where those are coming from. Because just having those conversations can really, really change the way you start thinking about that.
Thank you for that response, Julia. So I'm going to continue moving down the Q&A list here. I'd like to know more information on how to motivate. I think that was a response to the question that's currently on the slide there. Suzanne Baker asks, how do you implement a policy on fall and injury prevention to an entire province?
So I would say that is, I cannot answer that in 1 minute or 2 minutes, but I would say what we like to do is if you are planning to scale something up across a huge range of settings, I like to build something centrally. So do the steps that we talked about today, understanding general barriers and facilitators to fall or injury prevention, selecting implementation strategies, building those out from a central perspective, and then setting them up so that those implementation strategies can be tailored to the local setting. Because as you know, if you're trying to implement something across an entire province, you're gonna have a lot of different kinds of settings, rural settings, urban, suburban. You're gonna have a lot of different groups that you're probably gonna need to tailor those strategies. So the more you can centrally develop, but then allow local level tailoring, it increases the chances that people are not going to affect the underlying behavior change theory, but they're going to be able to do it at a more local level so that what they implement really relates to their community. So I'd say that's the shortest answer I can give you to what is a many-day conversation.
Great, thank you, Julia. Leslie Bennington has asked in the chat box, any tips or strategies for moving from dissemination practice to implementation practice, or how they could go hand in hand?
Well, so to start, they honestly almost always go hand in hand. I mean, dissemination efforts do not always have implementation stuff, but all implementation efforts are probably going to have some dissemination elements. I can't think of a time that you're not going to include some dissemination pieces. So I would say that they almost always work together, because ideally you should be understanding your barriers and facilitators, and probably you're going to have some pieces related to awareness and knowledge, so you'll have some dissemination in there. But I think that you're probably trying to get at what happens if you are starting in dissemination and how do you work towards implementation. And I would say the way to start is to figure out, who do you need to get buy-in from to get them to understand the value of implementation over dissemination alone. Because for a lot of organizations, they kind of put all their efforts and their work into saying, oh, we're going to disseminate stuff. And they don't even totally realize that that may or may not get them the outcomes that they want. And so by getting people to slowly understand, and in fact, motivating and inspiring them to think of the advantages of implementation science and how that could inform their work and impact, you can help move people down that spectrum.
Sarah Orshaw asks in the chat box, system change is where I work and money and politics are my barriers. Any tips on facilitators?
Okay, so I would say, so I have lots of thoughts, but I would say it's a little bit beyond this. So today we talked really about individual level barriers and facilitators, but there's also theories that we can use to help us think about system level change and how to address system level barriers. And so I would say that what you really want to start thinking about is the system level changes and how you can better understand how to address those and getting to deeper root causes. So when people talk about money, priorities, and time, I always say, well, that's like not a deep enough barrier. I want to know why there's no money allocated, why there's no time allocated to doing this. Why is this not a priority? But I would say that's an entirely different topic than the one I talked about today, but very important. Oh, and one last thing is, if you want to think system stuff, the National Implementation Research Network, NIRN, has a lot of stuff related to system change and implementation science.
Another answer in the another question, in the Q&A box. What's the best way to change staff's way of working after doing the same thing for 10 plus years and being disempowered to be creative in their work? We are trying to go from this situation to one where staff are encouraged to be more engaged in how they practice and assist the community.
That is a great question. So I would say chances are, it sounds like you're sort of tapping into the fact that there are probably individual level barriers, but it sounds like there's also some kind of community organization level barriers there. So I gave an example of the theoretical domains framework to help you think about individual barriers. But I would say you could also check out the CFIR, it's called, the Consolidated Framework for Implementation Research. And there's something called the CFIR, C-F-I-R guide.org, that shows you how to use the tool, and it helps you think about some of those contextual pieces and how those impact implementation. So just like we thought about what are the barriers and facilitators and how can you address them, you can think about some of those barriers and facilitators at the contextual level and think about how can you address those. So I'd say that's my fastest response to that one, to what is a very complex issue.
Another question in the Q&A, how does improvement science fit with implementation?
I love this question. So I actually spend a lot of my time right now working with people who've been trained in quality improvement. And there are some really great papers talking about how quality improvement and implementation science are complementary, yet sporadically interchanged together. They both have the exact same end goal of improving patient outcomes, but they come at it from very different perspectives. One, quality improvement, thinking about tools, local implementation, thinking about things like PDSA cycles. Implementation science is thinking about theories, models, and frameworks. What is the evidence? And that there are amazing synergies between how we can use these pieces together to really enhance the way that we're doing implementation. And so there's a couple of organizations in Canada right now, actually, that are looking really heavily at, for example, Canadian Patient Safety Institute is blending quality improvement and implementation science to create a kind of more enhanced way to implement things. So it's very, very fascinating how they can fit together.
Wonderful. Deborah Hawkins asks in the webinar chat, what do you mean by centrally develop?
So by centrally developed, I would mean that, so oftentimes we have organizations that might be like a provincial agency, for example, that could develop something that would then be implemented at a community or an organization level. So what that allows is that allows us to only need to kind of go through this process of identifying barriers and facilitators and selecting strategies one time, because we can do it through a central agency. So for example, I work with Public Health Ontario doing exactly that kind of work, right? Helping them build programs centrally, and then individual communities or organizations can tailor those programs. So centrally kind of being the organization level in which that is happening. Note that it doesn't have to be a provincial agency. I also do work, for example, with the Research Institute for Aging in Waterloo. They have 17 long-term care homes affiliated with them, but they develop these these interventions at this research institute that then get implemented in the 17 sites.
Wonderful. Thanks so much, Julia. So there are 3 more questions in the Q&A box that didn't get answered, but I am being cognizant of time. So I think our next step will be, I will try my best to collate all of the questions that were asked to Julia and send them to her to collect some of the responses. And Julia, if you're okay with that, we can post the responses onto Loop so that people can have access to the Q&A as well as the slide deck after this presentation.
Definitely. Can I answer one quick question though?
Absolutely.
So I see Masood's question about how do you pick a theory, model, or framework, and that's the $1 million question, I feel like. I tell people, think about them as if they are tools in a toolbox. If you pick one up and it doesn't look like it fits, then don't use it, right? Don't use a hammer to put in a screw. So you need to understand the function of what you are looking for. Are you thinking about individual change? Are you thinking about organizational change? Are you thinking about the steps or stages? And then from there, you look at the options that are available and you use those. There are not really psychometric properties of these, but I would say whenever possible, use what we call a meta theory, model, or framework. Meta being that they have consolidated multiple different theories, models, or frameworks to develop that one.
Amazing. Thanks so much, Julia. And I just want to take a minute to share information about our upcoming activity implementation webinar series that we are planning in preparation for Fall Prevention Month. And for those who don't know, Fall Prevention Month is our national campaign that is working to have a call to action to all organizations that play a role in preventing falls. And this year we have updated our website slightly, and we have engaged with a few presenters who will be talking about some of the activities that they have implemented in the past. And they will be walking you through some of the logistics on how you can grab and go and take these activities and implement them in your context and in your setting. So here are the dates. If you would like to receive more information about these webinars, please proceed to our Fall Prevention Month website. That's www.fallpreventionmonth.ca, and get onto our newsletter, and you will be sent links for the registration for these webinars. And so I would like to thank Julia once again for a wonderful presentation and some very practical, pieces of information. And thank you to all of the attendees today. Please don't close your window just yet. You'll be redirected to a webinar evaluation where we will collect some information from you on how you thought the webinar went. We always appreciate your feedback when it comes to these webinars so we can continue to offer high quality webinars in the future. Thank you so much, everybody, and enjoy the rest of your day. Bye now.